all the speakers love to do. So I'm just going to start sharing my screen. So just one moment. That should be coming up now. Just a moment.
Thank you.
Yeah, and just before I start, I'm just going to check with the audience, or Joe can tell me, is that clicking through the slides? Perfect. Okay. So prehab and rehab and the therapeutic radiographer. So I think most of the audience are pretty clear on the definitions of what is prehabilitation and what is rehabilitation. A little refresher there. So prehab is about preparing the patients to get them through treatment and try and reduce some of the toxicities. And rehabilitation is about restoring as much as we can that functionality. So when we think about prehab and rehab, what healthcare professionals spring to mind? Who's involved in delivering the advice, interventions and signposting? Oh, like the physio, definitely, that springs to mind because we've just seen the definition. It's about prehabilitation and prescribing exercise. Tick, the physio is in there. Occupational therapists, definitely they spring to mind because we heard all about rehabilitation is trying to restore that function and adjusting to limitations. Occupational therapist is in there. Dietitian, oh, absolutely. We all think about the dietitian. As we saw in the definition slide, it's all about healthy lifestyle and good nutrition. So the dietitian is definitely at the forefront of our mind. Oh, speech and language, the SALT, yes, they came to mind because again, we heard about restoring that function. Here we're seeing about the swallowing. So yes, SALT are definitely included in prehab and rehab. What about the therapeutic radiographer? Tumbleweed, I hear. I'm not so sure. Don't worry, you won't be the first person that's not quite sure because despite over 50% of cancer patients receiving radiation treatment as part of their pathway, a therapeutic radiographer receives very little mention in national guidance and policy. In my experience and others, therapeutic radiographers are often missed out and they're not invited to regional and national rehabilitation working groups and committees. Those therapeutic radiographers working directly in prehab and rehab often have to work very hard to be recognised by the rest of the AHP team of physios, dietitians and SALT. And I've heard this firsthand. And this is despite therapeutic radiographers being the only profession purely trained in oncology, and actually having oncology knowledge is a mandatory requirement of registration with the HCPC. It's not a mandatory requirement for any other healthcare professional. Do therapeutic radiographers themselves recognise their role in prehab and rehab? And again, just some of it becomes self-fulfilling prophecy because others don't recognise them. They don't recognise themselves. However, therapeutic radiographers are key to supportive conversations, putting the patient at the centre of care and facilitating decision making and supporting self-management. Why? Because they're in a very unique position, and therapeutic radiographers often see patients daily for up to 8 weeks of treatment, whereas they'll have interventions with other healthcare professionals maybe once for an hour. So whilst preparing for the presentation, I asked some of the key AHPs at the Christie, what would their top tips be? And these top tips could be for any healthcare professional. So this is from Paul Brown, SALT, and he said, radiographers every day should be checking about mouth care, asking about swallowing and promoting exercise to aid swallowing function. This is just an image from the Christie. Information about what patients should be doing, exercises when receiving radiation treatment. What did the specialist oncology dietitian say? Absolutely, the therapeutic radiographer should be involved daily. They should be weighing the patients, they should be recording it, and they should be highlighting any discrepancies to another healthcare professional if it's outside their scope of practice. And again, every institution should have some basic healthy eating literature that they can be promoting with their patients. What were the physio's top tips? Normalising talking about exercise. So I mentioned the therapeutic radiographer seeing patients daily. Ask the patients daily. Normalise it. Have you been out today? Have you been for a stroll? It's not all about doing a marathon and climbing Mount Kilimanjaro. Encourage patients to keep a daily routine and encourage them to take short bursts of physical activity. What did the complementary therapist say? We all know that cancer treatment can be an anxious time, but again, the therapeutic radiographer building up that relationship and seeing a patient daily is key. And they can be given a whole range of advice of ways to reduce stress, whether that's spending times with family, friends, having a relaxing bath, time with your pet, gardening, listening to music, whatever works for you. But again, the therapeutic radiographer is key because they build up that relationship with a patient. So really, in conclusion, prehab and rehab requires a multidisciplinary workforce. And we all know the key players that spring to mind, the physio, the dietitian, but absolutely the therapeutic radiographer is part of that MDT. And we're now going to hear from some great therapeutic radiographers who can give us some good practice of what's happening in their area. So first, over to my partner in crime, Jo McNamara, who's also a fellow with me at Macmillan and a senior lecturer at SHU. So I'll hand over to you, Jo.
Thank you, Hazel. Okay, so hopefully you can all see that. So in terms of prehabilitation and rehabilitation, Hazel and I came into our national Macmillan posts, and I suppose Hazel and I were in a really privileged position, Hazel with being the Proton Service Manager, and for myself working in education. We actually saw firsthand how maybe we did integrate very much with different disciplines. We had a lot of insight into curriculum design, working through maybe developing skills, knowledge and attributes amongst the healthcare workforce. But actually what we did find as we kind of started to talk to students, clinical colleagues, a multidisciplinary team, oncologists and service users, that actually maybe what our perception of how therapeutic radiographers featured within prehabilitation and rehabilitation wasn't actually what was happening out in practice. So we were really privileged to be able to get to work with the team at Macmillan to look at the PROSPER work, so the prehabilitation, rehabilitation and personalised care for people living with cancer. And as we started to look at developing some e-learning resources, we started to have conversations with lots of therapeutic radiographers. And actually, maybe our perceptions of how we were helping patients wasn't something that was realistically happening in the day-to-day scale, or that therapeutic radiographers weren't realizing that what advice they were giving to their service users and patients wasn't necessarily what they deemed to be prehabilitation and rehabilitation. So we started to kind of have some conversations. And we're really fortunate to link with Danny Hutton, who works as the program manager in the Northwest for radiotherapy. And Danny is a huge public health advocate. And I know he's done lots of public health advocacy around smoking cessation. And he did a small scale research project with one of my colleagues from Sheffield Hallam University. So we had lots of ideas about how we could maybe utilize some of his previous knowledge to look at prehabilitation and rehabilitation. So we are currently in the initial stages of a service evaluation where we're looking specifically at evaluating therapeutic radiographers' perception of their role, what knowledge they feel they have about prehabilitation and rehabilitation, the confidence levels that they have, because quite often I know that we might teach something at pre-registration or people might do postgraduate certificates, but actually having that confidence to have those discussions, elicit those conversations, and also refer or give interventions is very different. We also wanted to look at if there are any barriers of instigating some of this advice, and we are very much aware of kind of service delivery issues, manager expectations, also maybe around role descriptions, and also about maybe specialist roles within the department, which align more to some of those kind of advice giving roles that maybe the treatment therapeutic radiographers delivering the radiotherapy treatment on a daily basis weren't feeling that it was any way their kind of responsibility to have those interactions. So what we wanted to do was do a pre-questionnaire looking essentially across those themes, and then we would get them to complete the 2 Prosper personas that's available on eLearning for Health now. And by working through those, we would want to look at whether or not their knowledge, confidence, and maybe some of the barriers that they felt there were could change. So they would then do a questionnaire post doing the e-learning, and then hopefully 6 months later do the focus group to look at maybe how they were implementing any changes as a result of the e-learning that they'd done. So some of the research questions that we're looking at specifically is, what do the therapeutic radiographers perceive their role is, what their confidence is, what the barriers are, what the knowledge or skills that they need to develop the information that they're providing, and also some of their own perceptions. So we've developed a quite long questionnaire, and hopefully it won't be too arduous for them, but we're hoping that we'll get a really good response rate by incorporating what we are classing as champions, and they will be across the radiotherapy departments to hopefully try and promote and maybe nag a little bit some of our therapeutic radiography colleagues to complete some of these questionnaires, and also take part in the CPD of the e-learning. In terms of the outcomes and what we hope to achieve as a result of this is essentially to write a report that will go to the Society College of Radiographers to look at the research and potential highlights of best practice that have been observed. We would love to do a peer-reviewed publication that again would then be disseminated through clinical and academic colleagues, thinking about curriculum design and how we can take this forward. You know, is it pre-registration curriculum that we need to alter and adapt to ensure that prehabilitation and rehabilitation is fundamental to what it is that we're teaching all of our healthcare students? And then finally, a report to Macmillan and Health Education England, who are obviously funding our posts, and also with the creation of the e-learning resource. So that's all that we've got in terms of the research, but if anyone has any questions or queries or wanted to get involved, then by all means, please do contact us. So I shall hand over now to, is it Lisa's going next?
Yes, thank you very much. So I think Lisa doesn't really need introduction, but she's fabulous, and she's going to talk about proven prehabilitation for prostate radiotherapy and some fantastic ideas she's got to develop at the Beacon Radiotherapy Service. Lisa is a Macmillan consultant radiographer and leads the late effects service. So over to you, Lisa.
Thank you. Can you hear me?
Yeah, that's fine.
So I've remembered to unmute myself. Right, let me just try and share my screen.
Yeah, that's looking good.
All right, perfect. Thank you for letting me know. Okay, so I'm going to talk about prehabilitation for prostate cancer radiotherapy patients. So not that long ago, Macmillan brought out a really useful document about prehabilitation. And prior to that, they'd done a comprehensive evidence review looking at data for the last 10 years, so 2009 to 2018, about prehabilitation. And I had a little look at this before I started writing this little talk. And actually, of 182 primary studies, of that, only 3 were radiotherapy. So 161 is prehabilitation based around surgery for cancer patients. 18 was chemotherapy, but just 3 for radiotherapy. And of those, there was 1 that was head and neck, that was about anxiety, and the results of that were unclear. There was one about breast cancer patients and yoga and quality of life. Again, the results were unclear. And then yoga and mood, and the results were mixed. Looking back at the original 182 studies, there were only 8 prostate cancer studies. All of those were surgical patients, and 3 of those were the same study we analysed, which got me thinking, why is radiotherapy not really included in this, and what do we need to do? And even more surprising, because if we look at prostate cancer, which is the most common cancer in men, so there's over 47,000 people diagnosed each year, and around 400,000 people living with and after the effects of prostate cancer and prostate cancer treatment. And the primary modality of treatment for these patients isn't surgery at all, it's actually radiotherapy. So lots of patients go on to active monitoring or watch and wait. Many patients go on to hormone therapy, but actually the primary modality of treatment is radiotherapy. And we know, as Hazel said before, between sort of 50 and 60% of patients have radiotherapy, and that's ever increasing. So is it because these patients aren't really a candidate for prehabilitation? Well, actually, in my mind, they're ideal. So long-term survival for these patients is very high, 78% live 10 years or more. And these patients actually go on to remote monitoring. So they need to self-manage and they need to be able to continue into the future. These patients have lots of comorbidities, and a study by the UK Biobank looked at about 250,000 men, and of those, 4,500 went on to develop prostate cancer. And of these, the average BMI was overweight. A quarter of the patients have low physical activity. Over 40% of them drank too much. Some of them smoked. 59% had high blood pressure. And about 6% were diabetic. And actually, these figures here aren't different between the groups that didn't develop prostate cancer and did. They're generally a group of patients that have got comorbidities. 30% of men with localised prostate cancer will succumb to a heart attack or stroke. All the patients that come from radiotherapy, or nearly all of them, are on androgen deprivation therapies, and this is linked to an increase in frailty, a higher risk of falls and fracture, and loss of muscle mass. And actually, these patients are quite complicated to treat with radiotherapy, which we're going to look at briefly in a minute. And also, for these patients, we have a 12-week window of opportunity. So these patients go on to hormone therapies for about 12 weeks before they start their radiotherapy treatment. So we've got a huge window of time to do some kind of prehabilitation or some intervention to see if we can improve the outcomes for these patients. So I've got a picture here because I realise that not everyone is a therapeutic radiographer on this call. They rarely are. And there's a prostate here. I hope you can see my cursor moving there. So the bladder sits just above it, and the rectum sits just behind it. So the anterior wall of the rectum is very close to the prostate. This is actually a picture of a radiotherapy plan. It's a bit like a weather map or a heat map. So the red area is where most of the dose is, and the blue area is a lower dose. So the red area here is the prostate. The green area is the bladder. And as you can see, the bottom surface of the bladder is getting a very high dose. And this yellow structure here is the rectum, and again, is getting a very high dose here. So when patients come for radiotherapy, we do a CT scan in the treatment position, and we come up with this plan based on that CT scan. And then generally, this isn't everyone, but generally patients come for 20 treatments now, so over 4 weeks. And the idea is that we set patients up in the same position each day, we do a quick scan to check they're in the right position, and then we deliver the treatment. But actually, in reality, it's not quite like that because organs actually move. So the bladder fills, you get bowel gas, and the prostate can actually deform or move, so it can get squashed. If you look at the picture here at the bottom, so the red area is the prostate, the green bit is the rectum, and the blue bit is the bladder. So that's the planning scan. And this is when the patients actually come for treatment. And you can see the rectum's actually full of gas, which has squashed the prostate out of the treatment field and into the bladder. So now the rectum's going to be getting a high dose of radiotherapy here, and this bit of the prostate is probably going to get a suboptimal dose of radiotherapy. And in the long term, these changes every day can perhaps lead to normal tissues being irradiated, which can cause serious long-term consequences. And there's another example here where, again, the red area is a high-dose area treating the prostate, and this little orange circle here is the patient's rectum. And in the plan, 2.7% of the rectum received a high dose at 57 Gray. But actually, if we shift that by just 3 millimetres, suddenly 11.5% of the rectum receives 57 Gray. And this potentially could be the difference between someone developing long-term consequences further down the line. And we know the consequences of prostate cancer radiotherapy are quite widespread. So after 6 months, 38% of patients have urinary incontinence, and that's increased after 6 years. Erectile dysfunction, 48% of patients, 36% after 6 years, and about 1 in 20 patients has fecal incontinence. But actually in my late effects clinic, I also see rectal bleeding, pain, sacral insufficiency fractures, lots of psychological morbidities, and actually the symptom burden increases with time and the health-related quality of life decreases. So I'm hoping that this shows to you that these are really ideal patients for prehabilitation. So we've come up with a little project that we've called Be Prepared. So become prehabilitation before prostate cancer radiotherapy. So I've split this slide into two, showing what I guess what's come out from a lot of these talks is sort of traditional prehabilitation. So elements of physio, so cardiovascular and strength exercises, nutrition, psychology and lifestyle information. But actually we've kind of supercharged this a bit and come up with more targeted pelvic radiotherapy prehab, where we're going to introduce some elements that are suited to these radiotherapy patients. So perhaps pelvic floor physiotherapy to increase pelvic floor and muscle strength, which can improve bowel and bladder continence. And actually, there was a really interesting study from some Belfast physios who did this with prostate patients and found about 50% of them were doing pelvic floor exercises poorly, which can actually exacerbate problems with continence. We're going to have a nutritional element where perhaps we're going to introduce some information about low gas foods. So reducing the amounts of sprouts and baked beans that patients eat to try and reduce the amount of gas in the rectum. There's also some evidence that a high fibre diet is good. It can reduce side effects and late effects, and also talking about fluid intake with these patients. In terms of psychology, the counselling team have done some brilliant work here, and they've just introduced a Just Diagnosed clinic. So in that 12-week period between getting your diagnosis and starting your treatment, there's actually an opportunity to engage with patients so that they can get information and get support. We're going to look at sexual function, so an erectile dysfunction clinic, which at the moment we offer prostatectomy patients, but not prostate patients, and bowel and bladder function, so a proper assessment. So perhaps looking at which patients we're going to give enemas to reduce changes in their rectal volume and bladder filling protocols. Even simple information such as sitting on the toilet correctly can have real benefits for these patients. And actually some other tests which are probably quite important, we could perhaps look at getting some early information about bone health with a FRAX score to see which patients might be at risk of insufficiency fractures, and perhaps some blood tests which can feed into perhaps a Q risk score that can give us an idea of their cardiovascular risks further down the line. So in terms of a baseline, actually a lot of these people, as Hazel pointed out, already exist. So we've already got physiotherapists, dietitians, psychological support already in the department for cancer patients, but actually we're not tapping into it. So when we look back at our records, in the last 22 months, only 3 prostate radiotherapy patients have been to the physios, and none of those were before their treatment. In the last 19 months, no prostate radiotherapy patients have been referred to the dietitians. And as I said before, the counselling had just set up a Just Diagnosed clinic, and actually patients are really engaged and were seeking information about support, self-management techniques and information. But obviously then there was a pandemic which closed patients coming into the department. So what we want to do is introduce some questionnaires early on in the pathway and assessments to gather the same information across the whole pathway. And then we're going to risk assess and triage your patients to different levels of information or intervention, which is quite a classical prehab sort of the triangle model, with majority of patients just requiring information rather than full-on intervention. All of the patients will be having a 12-week exercise programme. They'll be offered pelvic floor input. They'll all be getting radiotherapy specific information, and then we'll triage them to see whether they need dietitian or counselling referrals if required. Now, one other thing that's coming out in my mind from looking at this information is lack of information flow or transparency. So I show this slide quite a lot, and I'm sure some of you might have seen it before. In radiotherapy, we record all of our information on a system called Mosaic. So we do assessments throughout radiotherapy with side effect management, but it's recorded on a system that no one else can see. The physio team put theirs on another system, the uro-oncology nurses on another system, the dietitians on another, and so on and so on. And actually, it makes it very difficult to understand what the trajectory for that patient is, or what they were like before they had any treatment. So by the time they turn up at a late effects clinic, it can take me hours, literally hours, to go through perhaps, several systems, hundreds of letters to find out, well, actually, what was their bladder like before they had any treatment? Is this related to radiotherapy? What did we do before they had any treatment? So what we're trying to do is put this in a much better format where we can all use this information sensibly. So in this slide here, this is a kind of general scheme of how we're going to manage these patients. So patients will have their diagnosis and perhaps some blood tests or things early on in the pathway. And at that point, we'll be offering support information about the fact that there's a prehab service and gathering this information. All patients will be triaged for personalised care planning for the usual routes of the physio, counselling, a dietitian, or the standard prehab package. They'll all get a 12-week exercise intervention. And interestingly, the NICE guidance for prostate cancer patients says that patients on androgen deprivation therapy should all get a 12-week exercise programme anyway to prevent muscle loss and reduce fatigue. It's just we're not doing it. We'll be looking at counselling and psychological support, nutritional support and information, and also some lifestyle advice such as smoking cessation. But they'll also be triaged by the radiotherapy team as well for personalised care planning for radiotherapy treatment. So radiotherapy specific information, sitting on the toilet properly, reducing gassy food, perhaps some medicines assessment. So we get many patients coming through who are perhaps on suboptimal medicines, or they're taking medicines that might perhaps increase their urinary function. They'll be getting a pelvic floor assessment and exercises, and also part of a sexual wellbeing initiative, talking about erectile dysfunction, offering treatments, and just maybe enabling those conversations very early on so that they know that they can ask about that if they want to further down the line. And then all of this information will be collected and shared somewhere where we can all access it, so we can see across the whole pathway what's been happening with these patients. And then on this next slide, it's exactly the same, but I've mapped over here who's going to be doing these things. So for instance, introducing the Prehabilitation initiative will probably be down to the uro-oncology nurses who see these patients right at the beginning of their journey, but also maybe part of a navigator role. The counselling team obviously involved with counselling and support, therapeutic radiographers with a therapeutic radiography side. The ones in green are the ones that we don't already have embedded within the department. So the navigator role for this initiative is actually the same role as a physio assistant. So this is the same person. The physio assistant is brilliant, and she's been very much involved in some of the rehabilitation initiatives that we've introduced. So she's already got lots of experience and lots of training with these patients. And the other person we haven't got is a pelvic floor physio. So really, all these people are here, they're just not being utilised properly. And then at the bottom, which I haven't mentioned before, is outcomes. And this is where it becomes a bit tricky, maybe. So there's a lack of standardisation, especially in radiotherapy, as to what we should have been collecting, which I think perhaps is why there's minimal research so far. So the green box here is from the Macmillan document, and a lot of these outcomes are based on surgical patients. So the first one being reduced length of stay. Well, our patients aren't staying, but perhaps we can map this onto something that's related to radiotherapy and make this a bit more useful for us. So we're going to look at reducing rescans and breaches, and I've got some data about that further on. Enhanced recovery following treatment, again, a surgical outcome, but for us, perhaps that's looking at reducing the number of catheterizations, reducing fatigue, and we've already got a lot of in-house data. We just haven't shared it with the right people. A surgical outcome, reducing post-treatment complications, but for us, we might be looking at bowel, bladder, sexual function, what their pelvic floor's like, whether they've developed sarcopenia from androgen deprivation therapy. I've also got late effects here, which I'll be coming back to. Smoking cessation, I think we'll be looking at self-reported or GP data. We can map on to improving cardiorespiratory fitness, and we're going to be doing the 6-minute walk test, grip test, and sit to stand like traditional prehabilitation models. Improving nutritional status, again, we're probably looking at self-reported outcomes, but we might look at some things like LDL levels, diabetes indicators, or BMI. Improving aspects of neurocognitive function, I've mapped on to perhaps improving self-management. So we were going to look at using the patient activation measure, and I'm not sure what we're going to do there. But already we've shown that if we offer some prehab, we can reduce appointments with a counselling team and implement some kind of self-management strategies. And then enhancing quality of life. So the QLQ30, which is cancer specific but not prostate specific, maybe the EQ5, D5L, And actually the Cancer Quality of Life project is moving forward. So we might have something else we can feed into us that will allow us to assess quality of life for these patients. So in our outcomes, we really want to look at improving pathways for these patients, sharing data and improving the patient experience. And actually, I spoke about looking at rescans and mapping that onto length of stay in hospital. So in our radiotherapy department, we had a look, or we did an audit of how many patients require a rescan because their bowel or bladder status isn't good enough for us to plan on it. So if a patient comes and their rectal diameter is more than 4 centimetres, they have to be rescanned. And actually, about 1 in 4 patients required a rescan due to bowel and bladder status, which is a huge number. 10 out of 25 consecutive patients had to have extra imaging during treatment due to their bowel and bladder status. An extra scan is obviously extra dose, but actually it's extra cost. And actually it's a huge amount of anxiety for patients and for staff who potentially have to keep trying to rebook 20 appointments every time they keep moving the planning scan. And the other thing we looked at was breaches due to bowel and bladder status. Breaches means that they're not starting their cancer treatment in a timely manner. And actually in cancer care, it's a big no. And in June to November 2019, we had 13 patients that breached and didn't start their treatment in time. In March to September, we had 20. And actually in January 2021, we had 6. And that was the worst in the country for January, which isn't a great metric for us, but actually, hopefully it means we can only improve and we've got something to compare against. So I've got a quick diagram here, which we found really useful when we showed it to the people who funded this to try and show what impact this would have. So in terms of radiotherapy, we spent a lot of time trying to improve treatment planning, improving the patient experience. In terms of radiotherapy treatment, we've now improved the way we deliver treatment to make it really accurate so we can reduce side effects. We've got a really good follow-up program where we can identify patients at risk of side effects. And actually here, unusually, we've got a dedicated late effects service, which is great because it gives us loads of data that we can look at further down the line to see what the outcomes are for these people. But what we're missing is a bit right at the beginning of the pathway. And when you look at it like this, it almost looks a bit ridiculous, doesn't it? So we're missing this first bit to get all this going. And if you think about the follow-up and the late effects, in terms of cancer care, we've recently spent a lot of money in terms of the recovery programme, living with and beyond cancer, with implementing holistic needs assessments, with implementing cancer support workers. And this is great, but actually it's completely ridiculous unless we've got this bit at the beginning. And if we can get baseline data and assessments and actually come up with personalised care plans, hopefully we can streamline this whole pathway. So in terms of funding, we've actually been really fortunate, and the CCG have funded us to do this project. So in Somerset, the CCG are absolutely brilliant. So in terms of things like social prescribing, village agents, the wider network for supporting patients, they've got some really good people and some really good thinking. So they've given us £40,000 for an 18-month pilot, which really, in terms of service development, is a tiny amount of money, and compared to the money that trial units or setting up a trial would get, it's absolutely tiny. And this is to pay for that navigator and physio assistant, which is the same role for 2 days a week, and to pay for a pelvic floor specialist physio. And actually we're really lucky because a physio has got lots of training in psychosexual problems and psychosexual information. So hopefully she can feed into the erectile dysfunction service as well. And interestingly, in terms of kind of integrated care, these people have come from all across the system. So the pelvic floor physio, one of them actually works in the community, and the community doesn't actually fund a male service at all. They're only funded to see female patients. So hopefully we can help, bolster their numbers and build that service in. Other staff groups, such as the dietitians and the counselling staff, have just been amazing in offering their support, and we're just going to collect data on how many patients we actually refer to them, with the aims of putting that into a future business case. So next steps, we're right at the start of this pathway really. So we want to look at what questionnaires we're going to give out, what are the best tools, how will that translate across the whole pathway, and where can we put that data for the best universal access. We're also still looking at outcome measures, and actually as a pilot, things are going to change as we go along. It might not be right from the beginning. And also potentially, how would this work with other cancer sites? So with prostate cancer, we're quite privileged because we've got this 12-week gap where we can build lots of different things and lots of time points to have a look what's going on. But perhaps for some different cancer types, we might only have 2 weeks. So we're using this to find out what is the pertinent information and what is going to be really useful. In terms of the late effects service, which is obviously where I fit in, it'd be really interesting to see whether if we offer prehabilitation, will this reduce late effects and improve the long-term management of patients. And actually, if you look at a lot of the studies, the benchmarking's been over a short period of time, so perhaps 30 days after their surgery, not really a long-term plan. So the idea is that we'll develop a research proposal to look at the outcomes of prehab patients and compare that to the historical data that we have here. And actually, not many sites have that kind of data, so we're quite privileged. And also for the non-prehab patients. And actually, it could be really simple, just sending out the same questionnaires that we've asked at prehab and comparing that. So finally, with this Be Prepared project, it's a local service development project, so we're looking at how we work together, a cost-effective way to introduce these novel pathways. And for other services out there who are trying to set something similar up, actually, in terms of radiotherapy, dietitians, physios, counselling, you will have this same sort of data about number of patients you receive for referrals and where they go to help you build a business case. And then the final thing I wanted to point out was your team members are already out there. And actually, the team that are involved in Be Prepared started out probably at one of these very first prehab seminars that was set up, and I had a little click on the participants list, and lo and behold, there was our dietitian and a couple of our physios. So I did a bit of emailing, which is how this all started out, really. So hopefully that explains kind of how we fit into this and what our aspirations are within radiotherapy to move this forward. Thank you.
Oh, thank you, Lisa. That was absolutely amazing. And I know personally I was hanging on every word, and the chat function's going a little bit crazy with lots of positive comments. And you've really put it into sort of facts and figures how radiotherapy gets forgotten about and how we can work towards looking after prostate patients who are radiotherapy bread and butter. So that was amazing. Thank you very much. And you might want to just look at the chat and pick up some of the queries. So now over to somebody else who's equally as fabulous. So Emma Hallam is also a Macmillan consultant radiographer and also works in late effects, and she's from Nottingham, and she's going to talk about rehabilitation and digital prompts for the head and neck radiotherapy patients. So over to you, Emma.
Thank you, Hazel. If I can actually share my screen. Okay, I'm pressing. Can you hear me? I'm sharing. Hello?
I can hear you.
Yeah, sorry. So I'm pressing share screen, but nothing's happening. That's good, isn't it?
It's not happening at the moment,
No.
But yep, we're coming. I can just see your shared screen, but I think you're showing your whole desktop, so I can just see the Teams. There we go. I've got your presentation. Yeah, yeah.
Okay, there we go. We're moving forward. Yeah, perfect.
We are.
Okay.
Perfect.
Okay, so obviously I'm here, as Hazel's just said, to have a talk to you about head and neck late effects, really, and some rehabilitation within that. So we know that living a life with a history of cancer is unique for each person, but there's a common thread, and that is that life is different afterwards. The effect of radiotherapy treatment can last a lifetime and can often have a devastating consequence on a patient's quality of life. Patients are often living with such consequences which are often ignored and not recognised by many health professionals, and evidence suggests that patients with late effects from cancer treatment can have a reduced quality of life if their complex needs are not addressed appropriately. So back in 2013, we were really fortunate to have funding from Macmillan to set up our Nottingham Late Effects service. This was a one-day-a-week service for any tumour site that provides advice and support to help patients manage both the physical and the psychological symptoms that they may be experiencing from their radiotherapy and chemotherapy treatment. Our aim was to provide highly specialised care for cancer patients throughout Nottinghamshire who are 6 months post-treatment and have been cured of their cancer, but again are suffering with these disabling consequences. We liaise very much with other specialties to provide this highly personalised holistic care. And in 2019, we were lucky to get some extra funding from Macmillan to fund my post as a consultant radiographer in late effects, but to work specifically with the head and neck cancer patients and be part of a head and neck cancer support and therapy team. And this is because this patient group represents the highest proportion of patients with significant unmet late effect needs that we're seen within the late effects clinic and are a real priority group of patients for the East Midlands Cancer Alliance. So just to show you then, so remembering that we were a 1 day a week service, we'd seen over 1,000 late effects referrals, but 383 of these patients were head and neck. And of those 383 head and neck cohort, the longest time from treatment was 43 years. And this patient had been living with these late effects for all of that time. But on average, it takes the patients get referred to us at 3 years, 9 months. So quite a long time, really, the patients are struggling. And they will always say to me, why wasn't I referred earlier? We were often relying on surgeons through the follow-up to think about the service and refer them to us. So just a little bit about the impact here. This is some work that was done by Bristol Myers Squibb, looking at the UK patient experience of head and neck cancer. And you can see there's a number of symptoms reported and also how that links to a change in self-reported quality of life. The problem with head and neck late effects is they're often bothersome and have this bothersome negative effect on a patient's quality of life. So for many people may say, well, it's only a dry mouth, but if your dry mouth then stops you, if you're a lecturer and you can't actually put a sentence together because your mouth gets so dry, I've had lots of patients have to actually give up their job because of a dry mouth. Also, patients' relationships break down because they're no longer able to kiss their partners anymore, and often can't sit and eat at a dinner table because their swallow function. So it has a real impact on quality of life. We also can affect the actual normal functioning of the organs in the head and neck. So patients will often have food sticking, be unable to swallow, and this can go on to severe life-threatening complications such as aspiration, but also carotid artery patency. Just wanted to touch now on the impact of lymphedema. Now, this is something that I've been working with since I started the Late Effects Clinic back in 2013 with the actual lymphedema service that we feed into. And we were finding that we could really work together, and with me getting really upskilled in lymphedema management. And this was so important because the majority of these head and neck patients will have some form of lymphedema. And just this slide here just shows you the physical impact that has there, but not only that, the social changes that come about because of the physical problems that patients have, but also the communication problems that brings. We have patients who can't see because they can't wear their glasses because their lymphedema around their eyes is so bad, so they can't read, and it will often also affect their hearing and tinnitus. And that's just from the lymphedema, not to do with the actual damage that the chemotherapy or the radiotherapy might have done to the middle ear. And we have this massive emotional problems. We have a lot of patients who come to our service with body image and survivor's guilt. A lot of patients do come to me saying, I wish I hadn't have survived. I'd rather not have survived than live I am now. And we also need to really think about radiation fibrosis. And that's because radiotherapy really is the gift that keeps on giving. And it develops this scar tissue because this build-up of this fibrin that happens. So if you've got that along tissues and organs where you've then got lymphedema as well, it's a double whammy for these patients. So the importance of lymphedema is that it's about early identification and intervention. And research shows that around 75 to 90% of these head and neck cancer patients will suffer from external or internal lymphedema, or even both. And identification of swelling at around 3 months or more post-treatment is the key time to be notified to recognising this lymphedema. The edema will often present as a heaviness and tightness and may be very subtle, and this is only the external lymphedema that we can see. And these early stages of lymphedema are reversible, but if untreated can lead to fibrotic tissue changes and resistant therapies. And remember what I was saying about the radiation fibrosis as well. So this early treatment and educating patients could really prevent late stage lymphedema and reduce associated burdens and improve quality of life. So as I said, I'm part of this head and neck support and therapy team, and the key members of that is myself as a therapeutic consultant radiographer, and I also have input from speech and language therapists and dietitians. And we provide a multidisciplinary support throughout the whole treatment pathway, from diagnosis to survivorship, using collaborative working. I must just say I actually pick up more with the post-treatment rather than the on-treatment now. But we really provide a more structured and coordinated follow-up. We give a clear signal to patients about rehabilitation, side effect management and ongoing care. And we've produced these digital prompts to really help identify patients' needs and make sure that who needs to review these patients is at that appointment. So what can our support and therapy team offer then? Well, obviously I predominantly do all the radiotherapy side effect management and all the psychological support, but they're all the things that we can actually offer. We offer in the late effects service that I've been able to bring over and input into the support and therapy team. And of course, I've got the dietetic support and the SALT support there direct as well. But in setting up the support and therapy team, we see all the patients at 2 weeks post-treatment, where we're really looking at this side of post-treatment side effect management. But we really thought to ourselves, what can we actually do to really try and identify needs earlier and get rehabilitation going? We wanted to stop seeing patients, 3, 4, 5 years down the line when really it's kind of too late to start working on some of these things. The late effects have really set in then. So we then developed this post-treatment rehabilitation clinic. And I just wanted to show everybody who's there. So again, it's myself as the main person really, and then I bring the SALT and dietitians in for we call them multi appointments. But I've just put the importance of lymphedema nurse specialist on there, and that's because she has given me all the training I need to provide the lymphedema service here. But I can have her on board if needs be, if it's a little bit out of my scope of practice or a bit out of my skill set. So we developed some digital prompts, which we are now live with, and it is going really well. And these have been based upon the EORTC questionnaires and also Lymphedema, which is basically late effects on normal tissue. And we use the doctor-doctor platform. And these digital prompts are being designed to identify patients' needs, both physically and holistic needs. And that was really important for us to get some holistic element in there as well. And also it gives us the ability to screen for late effects, to try and really pick up these things when they start to affect the patient, and we can track them over time, many months, many years. So it'll give us a whole picture of when these things start to develop and really see if we can get those interventions and rehab in earlier. What's important about the promise is that it's a patient subjective bother. We're not relying on a surgeon to say that, well, actually, yes, this stiff neck's now becoming problematic for this patient. It's when the patient feels it's a bother to them. It enables interventions to be tailored specifically to the patient and to their specific needs. We can reduce hospital visits and also reduce the need for onward referrals. So for the pathway then, obviously we'll always have the late effects referrals coming in at whatever point that is from 6 months post-treatment, but now all the head and neck patients are reviewed face-to-face at a 2-week post-clinic with myself, the dietitians and speech and language. And then at 4 months out of treatment, they do a digital questionnaire, digital prom. But I also have an appointment with them at that point, but it's usually via video, telephone or face-to-face if need be. And at that point, that's where I will bring the SALT and dietetics in if their questionnaire has flagged up that they need problems. The other thing that I will do at this point as well is I will then start them on the rehab program that was designed. So we've designed a specific home exercise program, which is aimed to reduce lymphedema, radiation fibrosis. And this has been developed with myself, the physiotherapy team, and the speech and language team as well. Patients will then move on to a 1-year digital review, and then they will also be reviewed at 3, 5, 7 and 10 years. We realise we can't keep going on with these patients forever, but hopefully by then the patients will really understand what we're looking for and will refer themselves back in at that time point if problems did happen. So the post-treatment team then really enables us to make sure that the patient is reviewed by the appropriate specialist, and it enables us to really combine and work collaboratively with for this patient. And what's important there is to make sure that we're all saying the same thing. We often found that patients were coming to us saying, well, I've been given all these exercises via the speech and language therapy, and then you've given me all these from lymphedema, and they don't know which are the most important. So we're really able to collaboratively work together and tailor a plan for that patient from all the specialties. It's great that the clinic format can be tailored to the patient needs, and this all hit around the same time as COVID, so it was excellent to be able to get our video clinics off. So we really try and reduce the patients coming unless I need to do some hands-on management with them. And again, like I said, this is this key point where I can introduce the rehabilitation aspect of this early identification of the lymphedema and this home exercise and management plan that we've developed to reduce fibrosis and to maintain function. So just thought I'd show some data on some of the data that's coming at the 4 months point. So of 81 patients that were reviewed at that point, 74 of them had got issues, but within that only 10 needed salt and 2 needed dietetic intervention. The rest of it was all stuff that I was able to deal with, so the lymphedema, pain, psychological issues, trismus, peripheral neuropathy and chemo brain. And then this is the 1-year treatment post data that we've got at the moment. And I think the returns of patients filling in was you know, pretty high, really. We only had 5 patients who didn't return their questionnaire or didn't fill it in online, shall we say. If they're not able to do digital, by the way, they can have a paper format of it. And 35 of those 43 that completed the PROM did need an intervention. And again, there you can see, again, it's similar stuff again, similar issues that the patients got, but then some additional referrals were needed. So we need to refer a couple of patients to dental, 1 back to the surgical team, and that was recurrence that I'd picked up, a couple to the specialist pain team because it was way beyond my scope of practice, and 1 to hearing services. This is just one of my patients. I wanted to just show the difference that in his lymphedema with the home exercise and management plan and using a special collar that we use for lymphedema management. And you can see that there over 3 months, the impact that has had on that lymphedema. And he would have just been left because his lymphedema was not severe enough to warrant an actual lymphedema referral. But as a therapeutic radiographer, I was able to come in, give him the exercises, help with the drainage, and hopefully he will stay. You know, this is how he's going to stay. Just some patient feedback. I know we're all about data, but I think the actual qualitative patient stories are really important as well. And just a couple I'd like to pick out here that we looks at me as a whole, not just a cancer. Made me feel that what I was experiencing is normal, and being invited to this appointment shows the department still cares about how you are getting on after you have given me the all clear. It's just some really nice quotes there. I just wanted to finally touch on collaborative working. I feel really lucky to be able to work with the other allied health professionals and the lymphedema CNS that I work with. I've learned so much from these other disciplines, and we really learn from each other, and we've really been able to upskill our own working and identify new skill sets and that we can offer to our patients. But it's about collaboration and discussion with these colleagues to really enhance an individual's patient journey. It's about being responsible for delivering a whole system, patient-focused approach, not rooted in a uniprofessional perspective. We're able to identify patient needs and what is important to the patient and reduce multiple appointments, which is beneficial to both the patient and to the trust. And we really can reduce the need for onward referrals and therefore reduce waiting times. Thank you.
Wow, Emma, that was another totally inspiring talk and really emotive to hear that some patients suffering with late effects actually wish they hadn't survived the cancer. That's you know, truly sort of hits a nerve, but so great to see you doing such great work, putting patients at the forefront. And actually, I think you hit the nail on the head. And I hope that's what's come through in today's presentations. It's absolutely about collaborative working. And the therapeutic radiographer is part of the team. And look, if we work together, you know, we've seen today what we can achieve. So I hope as the take-home message is don't forget about the therapeutic radiography. We want to work with you. We want to learn from you. And I know in my personal journey of setting up the Proton service, bringing in nurses, ODPs, physios, dietitians, that's the thing I enjoyed the most and is the thing I enjoy the most. And Emma said it, it's about learning from each other. So thank you everybody for listening. They will be recorded and Fran puts them on a secret website, which I think you've all got a link. So just to say thank you again to the speakers who were inspiring, and I'll just hand over to Fran to close.
Thanks a lot, Emma. I think you're still sharing your screen. Just
Oh,
in
I'm
case
sorry.
that you don't want to. It was totally inspiring, and the timekeeping was frighteningly good as well. But hats off to you all. I think there is just so much learning there. I want longer. I don't think an hour was nearly enough to give it all justice. So thank you very, very much. The next webinar we've got will be talking about Enable, which is again is one of the trials that's coming out of the MSRG, looking at the importance of supported self-management for people with cancer. I've also got the cancer care map people coming to give a bit of an update, because they are really good at publicising some of the services out there, and I think it's useful just to know about their governance. And then we've got David Wright, who I think everybody is a complete star and most people know here, with a colleague, Kate Lippier, equally great, to talk about theory of change, which again I think is quite important in terms of the new services that are happening. For the July session, what I want to do is a bit more a sort of question and answer type one. So we will have a panel of experts, because we do get some really brilliant people coming in to listen to this, and you are all experts in your own field. But if you have queries that you want to bring to the team, I think it might be quite useful. So if you can think of things that you want to talk about, services that you're thinking about developing, or issues, or anything that's worked really well or where it's been a bit challenging, then if you could let me know, that would be grand. So look forward to seeing you in June, when hopefully the weather will be a lot warmer. Thank you again. Take care. And as I say, once I've managed to get the recording out, we'll save it all on the Wessex Alliance website. Thanks all. See you again. Bye.